Our first speaker, Dr. Raju Gopal, who will speak on management of erectile dysfunction in diabetes. Let's welcome Dr. Raju Gopal. We hand over the session to our chairperson.
So good afternoon all, and I think Samaga sir will be joining us soon. I think an important topic which is often not discussed that openly, and it is practically relevant. So managing erectile dysfunction in diabetes. Over to Dr. Raju Gopal for this session.
Good afternoon, chairpersons and my dear colleagues. And outside I thank Ganesh and the team for giving the opportunity to present before you. As the chairperson mentioned, it is probably the most important complication, probably patient's point of view. And often we are not treating it at the adequate level because of various reasons. I'll discuss that in the coming slides. So what I'm going to quickly review on the prevalence is not, and what the proposed mechanisms behind the erectile dysfunction. What is the relevance of identifying it early and to treat them, and what are the treatment options in detail. So this is not a very underreported, underestimated problem. It's a significant increase. Significant population prevalence is there. If you see one data from India is by Ganesh only. Actually, we did publish in 2009. 15% was the Indian data. This is the first probable Indian data reporting in diabetes patients. Then, depending upon the subsequent publication in 2014, you can see it's about 20% in mild to moderate severe ED, and severe ED in about 21%. 17 data again says it's even more, like 52%, and overall prevalence, and in type 2 diabetes is 66%, and type 1 is even less, it's lesser. So it's like a significant problem, very commonly occurred, but we don't underreport it because of we don't look for it. So what is the pathophysiology of erectile dysfunction in type 2 diabetes? It is same. It is same like any other erectile dysfunction in any other patients: vascular, neuropathic, endocrine factors, and psychological. Of which vascular and neuropathy is more likely to be happen in diabetes because of the inherent problem with the disease. So when you have a diabetes, the comorbidities like obesity, dyslipidemia, hypertension, hypogonadism, depression, folic pharmacy, all can contribute. Similarly, the patient with the neuropathy, autonomic neuropathy is well known to cause erectile dysfunction, microangiopathy, arterial stenosis, and microangiopathy in the form of endothelial dysfunction. All will contribute to the development of erectile dysfunction. So why should we identify this? Suppose this is a very clear indicator of poor glycemic control. And the thing is that it actually allows to a comprehensive review of glycemic management and cardiovascular risk. And as you all know, it predates overt cardiovascular disease and serves a clinical clue to underlying endothelial dysfunction. And as mentioned, that's one of the most distressing diabetic complications and impairs the quality of life significantly. And addressing the ED can actually improve the adherence to a diabetes management. Suppose you're able to address the ED problem of the patient's adherence to the treatment is definitely increase. Similarly, a timely diagnosis also helps to identify the associated risk factors, associated complications, and you can optimize them by using the good diabetic control and the pharmacotherapy. So what all things you should ask for when you evaluate for ED is, you should ask a detailed history about the sexual history, assess the onset, what is the duration, what is the symptoms has to be analyzed so that the severity can be assessed. Ask for the nocturnal and the morning erections, ejaculation issues, libido. All these questions has to be asked in a not judgmental manner, taking a lot of time. And medical history, you should ask for the duration of diabetes and the control of diabetes, presence of other comorbidities like hypertension, diabetes, dyslipidemia, CVD, and other comorbidities. Lifestyle factors like smoking, alcohol, physical activity, and psychosocial stresses all has to be in detail noted. Medication review also very important because antihypertensives and antidepressants can actually cause or leads to erectile dysfunction. Physical examination, you have to look for the penile structure, testicular size, very important. Secondary sexual characters, and vascular assessment, peripheral pulses, and look for other evidence of vascular disease, The neurological examination, diabetic neuropathy has to be looked for. Anyway, we will do that, but also has to be done in detailed examination. When you, with the blood investigations, definitely blood sugar control has to be looked at, HbA1c and fasting plasma glucose, lipid profiles, creatinine. Then you look for testosterone, because once you have a testosterone, you can identify hypogonadism. And suppose testosterone is low, you will look for the FSH and LH and prolactin, also thyroid function test. So these are the general tests we do in patients with evaluation for ED. So lifestyle, the management part, it is lifestyle modification and the pharmacological intervention. I think the second part, the pharmacological intervention, is what we as physicians are more seriously doing, and this is something which we are entitled to do. Other non-PDE, that is the phosphodiesterase inhibitors therapy, are actually limited, and our experience also is very limited. So first line management, you have to control the diabetes properly. Suppose the blood sugar control is very poor, they are likely to, ED is unlikely to improve. Blood pressure control, lipid targets has to be achieved, weight reduction, increased physical activity. If smoking is there, you have to stop smoking, and more alcohol has to be reduced, to be taken only in moderation. Now the treatment part, you have oral phosphodiesterase type 5 inhibitors. Okay, so this is what we generally have something to offer to the patient apart from the general control. So first line is sildenafil, tadalafil, vardenafil, avenafil. These are the 4 agents probably available for us, of which sildenafil and tadalafil probably we are using more. And efficacy is going to be lower compared to the general population. So that this has to be kept in mind before you start treatment. And another one way of giving tadalafil daily dose also helps in to maintain good erection and improved endothelin-dependent vasodilatation. As we all know, it is contraindicated in nitrates and certain cardiac conditions. So this is the comparative data of these 3 molecules, that is sildenafil, tadalafil, and vardenafil. So among which sildenafil is short-acting, and vardenafil also, while tadalafil is a long-acting agent, 2 hours is onset of action. So you have to take accordingly. And duration of action is about 8 hours in sildenafil, short-acting, while tadalafil is long-acting. Oral bioavailability is poor with sildenafil and vardenafil, while it is very good with tadalafil, 80%. And the meal-related decrease in the absorption happens with sildenafil and vardenafil, while tadalafil has no effect. So that's the advantage of tadalafil over other agents. You can take it any time and without the respect to the last meal. And side effect profile, I think it's all same in all the agents. It's headache, ocular and facial erythema, hyperemia, then nasal congestion and back pain. And drug interaction, nitrates, amiodarone and warfarin. These are the 3 agents are contraindicated. Probably patients who are already on nitrate should be not be given offered these agents. And tadalafil, nitrates and amiodarone. So amiodarone, what it does is actually it increases the, vardenafil is actually contraindicated. Amiodarone causes cardiac arrhythmia. Here also, apart from cardiac arrhythmia, the chance of amiodarone will actually reduce the metabolism of these agents. So we have, it will be used in caution with tadalafil and sildenafil, where vardenafil, it should not be used. Now the problem is that once you give these agents, most of the time, at least say 50% of the time, patient comes back to you and say there is no effect with these agents. So this is then the problem actually starts. Those patients who respond to these agents, we are safe and the patient is also happy. But the problem when patient does not respond to the agents, first line agents, then the problem. But many of times, if you ask the history very detailed, there will be some problem the way we are taking this thing. So it should be taken at least 30 minutes advance for sildenafil and vardenafil, while 2 hours prior for tadalafil. So this time gap should be adequately followed up. And avoid a fatty meal in case of sildenafil. And this is not a magic pill. So you read a physical stimulation and mental stimulation. There's nothing can replace that. You can only augment the erection. And second thing, before calling it as a failure, you have to use it several times. Okay. And another thing, at least drug should be changed. Suppose you are using a tadalafil, you should change to sildenafil and C. And you should use it at least multiple times before calling it as a failure. And you should always talk to the patient what they can expect as a side effect, like especially headaches and hyperemia and vasodilatation things. So these are the detailed list of PDI failure. Before declaring PDI failure, you have to ask for the as I mentioned, time, duration, maximum dose adjustment has to be done. Suppose you're starting with a small dose, you have to increase the dosage. The need for sexual stimulation has to be should be explained to the patient, and quality of medication is also important. And food and alcohol effects in also has to be mentioned, and trial of different PDIs before you call test failure. And the most important thing, unless suppose you are not measured the testosterone level and not diagnosed hypogonadism, such patients, if you give PDFA, they are going to not going to respond. So that has to be kept in mind before calling them as a failure, treatment failure with the phosphodiesterase inhibitors. So this is the diagram says that once the phosphodiesterase inhibitor fails, what you have to do? Then you have some options like you can use antioxidants along with these agents. Sometimes it may help. Intracavernosal injections, topical or intraurethral prostaglandins, vacuum erection devices, and novel therapy. I'll discuss in the coming slides. The thing is that these are not very commonly used, and very difficult for a physician like us to use it, because our experience is very limited. Many things can be done by us, but I think none of us are doing that. So this is the first thing we can do. Suppose there is a phosphodiesterase inhibitor failure, we can start using other agents like L-arginine, L-citrulline, or a propionyl L-carnitine, of which I think L-arginine is the most commonly available. L-arginine sachet, 5 gram sachet, can be taken along with these agents, which actually helps in the vasodilatation and increases the erection. So the problem is that there is no randomized control trial, not even leave alone randomized control trial. There are very few trials that also having a very low quality evidence we have. But these are being largely used because this is what we are left with once the patient is having a failure. This is the intracavernosal injection therapy. So this is not a new therapy, it's very used as early as 1980. So what it does is you are giving injection, intracavernosal injection, different preparations. So you have a monotherapy, you have 2 agents, 3 agents. So these are the agents being used. This is pepaverine, 30 milligram per ml, and phentolamine, 1 milligram per ml. That is the bimix. Trimix, along with that, you add prostaglandin 10 as well, 10 microgram as well. Then Invicorp is another agent, avipadil and phentolamine as a mix. So these are the agents personally I have never used. I don't think many of us are not using this, but this is an effective therapy if the patient has been rightly trained to do. And availability of this medication also might be a problem because, as I said earlier, the usage is very limited. So this is, but I don't want to read the whole thing, but the interest of mine is that the erection, the efficacy response is pretty good. If you see 83%, 82%, that means this therapy is very useful. That is what I want to stress. Only thing, we don't use it, but this is one therapy. Probably if there's a failure, it can be used because the response is excellent. Now, much easier way of using is the intraurethral prostaglandins. Alprostadil is the one agent which we are using topical. It's much easy to use. What is actually helping here is the high absorption rate from the urethral mucosa. Less than 10 minutes, a good absorption of this agent, prostaglandins, happens to the penis, and prostaglandins actually causes a vasodilatation of the erectile tissue, increases the cavernosal arterial blood flow, and that's by helping in the having a good erections. But the patient's acceptance is good, but as I said earlier, unlike intracavernosal injections, the effectiveness is not as good as ICIs, even though it is much easier to use. Now that also fails. You have a system called a vacuum erection device. It's a manually operated device. With using negative pressure around the penis, you actually cause a passive engorgement of the sinusoidal spaces, and they're having a good erection. Maintenance of erection is facilitated by using a rubber cuff applied at the base of the penis, and it is also effective in about 90% of the patients. This is the data. Again, not a large number experience is there, and this is what actually looks like. The problems are that you can have a side effects because of pressure effects, fatigue, coldness, bruising, and redness, and it can also lead to painful ejaculation. So also has to be used in those patients are on anticoagulants, or those patients having bleeding disorders should be used with caution. Then the last one is the penile prosthesis. Again, it's the last resort, end-stage treatment of ED in diabetic patients, reserved for those patients who do not respond to ICI or a vacuum erection devices. Comprehensive patient counseling has to be done. Both malleable and inflatable prostheses are used in patients with diabetes. Again, experience is limited, so it should be used with patients by surgeons who are doing it regularly. Again, it is not very difficult to find out a surgeon who is doing this. Now, the two novel therapies for this. One is the low-intensity extracorporeal shock wave therapy. So this is what we used for the lithotripsy in urology. The same thing is being used with the lower intensity extracorporeal shock wave. And there is some data coming up in terms of stem cell therapy and platelet-rich plasma, PRP infusion. So low-intensity extracorporeal shock wave therapy is same thing. We are using the shock waves to induce neovascularization in the erectile tissue in the penis, which helps in the enhance and restore the erectile dysfunction in patients with vasculogenic ED, like a diabetes. Stem cell and plasma-rich plasma is very under investigation, and right now we have mostly animal studies, and there are very few human studies, and still limited as experimental therapy. You can only mention it as a upcoming therapy. It is not, experience is very limited. But before, as I said earlier, suppose you have started this patient on the patient comes with ED symptoms, erectile dysfunction symptoms, and you start straight away on a phosphodiesterase inhibitor, you may sometimes miss a hypogonadism. So if you miss hypogonadism, this is good. So you have to do a testosterone, early morning testosterone level to understand and identify there is a coexisting hypogonadism. If it is there, it has to be treated with testosterone, and this has been shown to improve the ED symptoms in all studies. There are a lot of studies right now coming up in type 2 diabetes, hypogonadism, and all the studies, across the studies have shown that improvement in the ED symptoms. Okay. This is one publication where I did as my DM student, and this was what we did was looking at the hypogonadism treatment with testosterone. It's a randomized control study. We did for short period, 3 months to give treatment, and the placebo was given 1 gram, other arm was given testosterone, and that was switched over. But we could not find if beneficial. Actually, we are looking at the metabolic parameters improvement, which was not very clearly seen in my study. But at the same time, there are 1 or 2 studies have shown there is a benefit in the insulin resistance and dyslipidemia. But our study, it was not conclusively proven the metabolic benefit. One more thing is the adjunctive therapy. Suppose this is the one point which we as an endocrinologist or a physician miss very badly. The patient may have a sexual therapy should be required. Psychogenic causes of ED is well known and very common. Unless you identify this thing, none of the therapy is going to work. So you have to have as a couple therapy is required. So both sexual partners has to be interviewed together and separately and identify this problem. And for the better management, probably may refer to a psychiatrist who is actually dealing with such problems, which can actually help in a lot of patients. I think my practice, I think at least 5 to 10% of time we have to refer these patients to a psychiatrist or those who are actually dealing with this thing. And many times it has a favorable outcome. So what I want to end my presentation with, this is my messages. ED in type 2 diabetes is not very uncommon. It's extremely common, highly prevalent. And you should do, like any other complication screening, annual screening should be done for ED. Prospectively, should look for. And it is an opportunity to identify the endothelial dysfunction and CVD risk. For the treatment part, you need to treat the diabetes and lipids and blood pressure well. And PD, this phosphodiesterase inhibitor is the only probable therapy and the first line therapy and the only therapy probably we are well versed with. Use it judiciously and use it as a combination. And alternative therapies are only for those patients who are not responding to PDA5. But as I mentioned earlier, before calling it as a failure, you have to extensively look for the causes. And also, you should address the hypogonadism if present. And also psychosexual support also should be given the patient in appropriate patients. My sincere acknowledgements to Ganesh for giving some of the slides, and thank you for your attention.
Thank you, sir. The dais is now open for discussion.
Thank you, sir, for a lucid presentation. one of our urologists uses, if they don't respond, they use low dose continuously on a daily basis, irrespective of the meal. So, how effective is that, and what is the dose that we can use at a low dose continuously? And intermittently, they give a higher, like a short acting one, whenever they.
I think there is I presented in one slide that is that's a very effective in our clinical practice also. I think that is one of the good ways of managing it. Giving a small dose, that is 5 milligram, tadalafil is the one we generally give, and SOS as and when required you give a amlafil, avnavir, or you give a tadalafil 20 milligram dose, or 50 milligram avnavir, or 100 milligram avnavir you give as a this thing. That is more effective than. Suppose the patient is not responding to the conventional thing, that's the best thing. And second thing, the acceptance of low dose is much better compared to this 20 milligrams.
Any side effects long term we need to?
Long term side effects are not much described. I think it's only short term. The problem is I felt 2-3 things. One is the cost, second is the side effects. These are 2 things. Cost is not a concern because it's a felt need for the patient. Really, the cost, in this aspect, most of the patients don't complain. So cost may not be the issue, but if you're taking the long term, which is the cost also comes up. Side effects thing, I think this, apart from this, what you call short-term side effects, other side effects are relatively less. Thank you, Mahesh.
I think as the disease itself has symptoms which are vague, it could be functional, it could be over, identifying the symptom, and there's no diagnostic test per se possibly to say that, and it would take a lot of time for a physician who would want to go on to evaluate it. But yes, the treatment for it is rewarding. If people do respond to it, generally they do respond well. And even if, nothing other than even your phosphodiesterase inhibitors, even multivitamins with something else, with a combination of that, it's more of what we speak to the patient possibly would give them the hope and benefit in that way. And something that is, I think, sir, it's seen much more earlier, even in florid neuropathy wouldn't have developed. You would see this much early in the disease.
Yes, that is the problem. Sometimes the patient, their expectations are different. That also you have to take in consideration. It is very, very common than what we think. That is one thing for sure. Second thing, I think, suppose you are able to manage their erectile dysfunction well, their follow-up with you is going to be good. Even not with you, like their management also going to be much better. That's a window of opportunity you can actually act in.